Hi everybody. Today we'll discuss about pheochromocytoma and paraganglioma resection and anesthetic management. This is the part one of the discussion where I will be talking about the definition, the etiology, pathophysiology, clinical features, diagnosis, the medical management, which is mainly the preparation of the patient. They are the endocrine tumors originating from the neural crest-derived cells of the adrenal medulla when they are called as pheochromocytomas, or they could be derived from sympathetic or parasympathetic paraganglia when they are called as paragangliomas. Together, they are referred to as PPGLs nowadays, paragangliomas and pheochromocytomas together. They carry similar features clinically. They have got similar anesthetic considerations and produce catecholamines. It could be epinephrine, norepinephrine, and dopamine. The term pheochromocytoma was first coined by Professor Ludwig Pick in 1912, where he found that when the tumor, which was reddish green color, was fixed in Muller's chromate solution, turned brown. This was because of the oxidation of catecholamines stored within the granules of the chromaffin cells. It's basically a Greek derivative where pheo means brown, chromo becomes the color. It has got a prevalence of 0.2 to 0.6%. In fact, accounting for less than 0.1% of all cases of hypertension, affects all age groups, especially 40 to 50-year-olds of both the sexes, and it's got an annual incidence of about 0.8 per 100,000 person years. Younger patients are more likely to be affected if there is syndromic association, or if it is symptomatic, or a bilateral tumor, or there are extraordinary tumor. 80% of the condition is sporadic, whereas 10% of the condition can be associated with syndromes such as multiple endocrine neoplasia 2, Van Hippel-Lindau syndrome, and neurofibromatosis type 1. There are associated manifestations when we talk about these syndromes. For example, MEN type 2A could be associated with medullary thyroid cancer, primary hyperparathyroidism, and others. The MEN type 2B could be associated with medullary thyroid cancer, mucocutaneous neuromas, skeletal deformities, joint laxity, etc. And Von Hippel-Lindau again could be associated with multiple manifestations, including hemangioblastoma, retinal angioma, papillary cystadenomas of the epidermis and the broad ligament. So multiple organs are involved. Neurofibromatosis type 1, of course, will be associated with neurofibromas with multiple bony abnormalities, CNS abnormalities, and others. So where are these tumors located? The pheochromocytoma, much of it is located in adrenal medulla, 80 to 85%, and 15 to 20% could be paragangliomas, mainly the sympathetic and the parasympathetic also, common in abdomen, and they are mostly benign in nature. About 10 to 17% could be, of course, malignant. When I talk about abdomen, it is more commonly seen near the origin of the inferior mesenteric artery, the so-called organ of Checker-Cantle, the junction of the left renal vein and the inferior vena cava, and others could be neck, chest, and the urinary bladder. We were hearing about the rule of 10 when we were young, and students were taught and teachers were asking this question very frequently, the rule of 10, which is however outdated now because of accumulating data. Previously it was about the tumor being 10% malignant, 10% bilateral, 10% extraordinary, 10% extra-abdominal, 10% in non-hypertensive, and 10% being hereditary. So being a mass arising from the adrenal medulla, we should remember about the functional considerations. Basically, it is mainly about the catecholamines, the metabolism, synthesis and metabolism. The cycle starts from phenylalanine, goes to tyrosine product conversion to tyrosine in the presence of phenylalanine hydroxylase to DOPA to dopamine, and in the presence of dopamine beta hydroxylase to norepinephrine, which can get converted to normetanephrine or to epinephrine, then to metanephrine. And this last step is activated and kept busy by COMT or PNMT, basically. And of course, the norepinephrine and epinephrine are more likely involved in the effect upon the adrenergic receptors, alpha and the beta. In fact, norepinephrine and epinephrine combination is seen in 85% of the tumors as production, and 15% of the tumors secrete predominantly epinephrine. So based on this also, the manifestations differ. So when I say norepinephrine and epinephrine combined together, it is very common. Patients would present with sustained or episodic hypertension. Mainly the alpha-adrenergic effects predominate. There will be systolic and diastolic hypertension and reflex bradycardia. When it is predominantly epinephrine, it is beta adrenergic effects which predominate. There will be systolic hypertension by diastolic hypotension. And there will be, of course, tachycardia and tachyarrhythmias, mainly as a beta adrenergic effect. And unusually, dopamine is secreted, wherein hypotension would be the significant clinical feature. What will be the clinical features or presentation? It could be anything as shown in the table. It can occur in a paroxysmal or episodic manner. Symptoms could be headache to flushing to diaphoresis to palpitations, anxiety, abdominal pain, dyspnea, and others. And whereas signs could be, of course, hypertension, tachycardia, plus patient can present with cardiac outcomes, including heart failure, orthostatic hypotension. So, in fact, previously a classic triad of palpitations, headache, and episodic sweating was discussed. It was called as PHE, but it is seen, as I told you, only 40% of individuals. And you can also have a small way to remember. We can talk it as mention it as 5Ps: pressure, pain, palpitation, perspiration, and pal. Right, as you can see in this table. Of course, beyond the blood pressure and the heart rate considerations, the organs are mainly affected. Of course, it's the central to everything is the heart. The patient can have dysrhythmias, cardiac ischemias, or MI, may present with cardiac failure. They may present with cardiomyopathy, chronic, or it can present with acute Takotsubo-like condition. And because it is a hyperadrenergic state, the glucose metabolism is also affected. Patient can have insulin resistance with hyperglycemia, and there is also risk of hypoglycemia at the other end when you are managing the patient. And because it is the adrenergic fibers which are being affected, it's a matter of chronic vasoconstriction and intravascular volume depletion also. With contracted blood volume, the patient is also at risk of going to lactic acidosis and acute renal failure. So we are talking about the cardiovascular system, the kidneys, and the glucose metabolism overall. What you have to remember is the symptoms and signs can be precipitated by certain factors that would include physical overactivity, trauma, and even delivery. And small procedures like FNAC or biopsy can precipitate. And the patient is taking certain medications and items which have high tyramine content. It could be chocolate, coffee, smoked meat, red wine, and others. In fact, this is a table obtained from the Journal of Cardiothoracic and Vascular Anesthesia, a review article where they got so many drugs which can precipitate an attack of hypertension in these patients. In fact, this is an article where a patient was administered dexamethasone as part of antiemetic prophylaxis along with induction agent. They found that suddenly the patient developed into a hypertensive episode. Differential diagnosis for Pheochromocytoma, we should remember the zebra culture in medical practice. It's like when you hear hoofbeats, think of the horses, not zebras. So try to look for the more frequent reasons like severe hyperthyroidism, preeclampsia, and menopausal syndrome. Try to find it out. But of course, it is definitely dangerous to misdiagnose the condition. If indeed there is a Pheochromocytoma, it is advisable to go through the diagnosis. So how do we diagnose? Diagnosis is based upon the simple principle that the tumor produces a lot of the catecholamines. So what we should be doing is plasma urinary measurements of catecholamines and the fractionated metabolites like normetanephrine and metanephrine must be detected and found out. Hence, the screening test for the paragangliomas and the Pheochromocytoma is the measurement of catecholamines or metanephrine in 24-hour urine sample. There are guidelines on how to collect all these things. And the most sensitive test would be the plasma-free metanephrine levels. The patient's blood is drawn in the supine position, or the urinary fractionated metanephrine levels. In fact, the Endocrine Society guideline says, in terms of trying to assess the levels of the catecholamines or these metabolites, liquid chromatography with mass spectrometry or electrochemical detection methods are better than the laboratory methods to establish the diagnosis of biochemical PPGL for the patient. So, in fact, these are the different levels of the plasma-free metanephrine and the metanephrine you can see here. For diagnosis of the Pheochromocytoma and paragangliomas and to rule out. So, values above 400 picograms per ml, which is diagnostic in terms of free normetanephrine. And if it is less than 112 picogram per ml, it also PPGL. There are certain indirect methods of diagnosis. This is applicable when we have got doubt. We have only mild elevations or metanephritis, but your mind says definitely there is greater risk of PPGL in the patient. Of course, it's not mind alone. It's the clinical features and all the manifestations. We have got what is known as the clonidine suppression test. Again, on the principle that clonidine as an alpha agonist can inhibit the neuronal norepinephrine release in patients without PPGL, not from the autonomous tumor, because pheochromocytoma is an autonomous tumor. But there are preconditions. If the BP is less than 110/60, please don't attempt the chlorine suppression test. And also be careful in patients who are volume depleted. And before we take up this study, this assessment, the diagnostic test, you must stop drugs like beta blockers so the patient is on for about 48 hours. An IV cannula is placed, patient is laid supine for about 20 minutes. Then the blood sample is drawn. Then that's for the basal values. Then chlorine 0.3 milligram oral is given to the patient. And after 3 hours, the second blood sample is drawn. And throughout the 3 hours period, the blood pressure and the pulse of the patient are noted. In a normal patient, there will be fall in plasma catecholamines because of the alpha-2 effects. In patients with pheochromocytoma, there will be increase, or there will be not more than 40% increase. There will be 40% decrease and less than that from the basal. And equivocal results are also seen 5 to 10% of the patients. The second indirect method is provocation testing. Drugs like glucagon, histamine, tyramine have been tried. But last two, histamine and tyramine, have found to be very dangerous when we attempt it. Glucagon is the best drug, and it is very specific. It acts directly on the tumor to induce release of catecholamines. When you administer this, positive test is indicated by an increase of 3 to 4 times or more than 2000 picogram per ml of the catecholamines within 1 to 3 minutes. It is performed only if the diastolic blood pressure is less than 100 millimeters of mercury. In fact, if you have primarily epinephrine, it means that the patient has got adrenal mass. And if it is primarily norepinephrine, patient can have both adrenal or extraadrenal origin of the tumor. Then there are imaging modalities. Imaging modalities are taken up not as a first test, they are taken up after the positive serum test or urine test are obtained. Okay, they will help in localization of the tumor. So we have got two major options: contrast CT abdomen and magnetic resonance imaging, MRI. Contrast CT is very useful. It detects more than 95% of the adrenal masses of more than 1 centimeter diameter. Contrast is used, but therefore we should be very careful in patients with renal dysfunction. So we can have the size and presence of metastasis in the patients apart from the location, and it is 85% to 94% sensitive to detect the pheochromocytomas. Magnetic resonance imaging will be ideal when we don't want a patient like children to be exposed to radiation, and where you cannot give contrast to the patient and it is safe not to give. And sizes less than 1 centimeter, we can identify better with MRI. There are other modalities which are also available. Again, if there are negative or inconclusive biochemical results, or non-localizing CT or MRI, or when there are metastatic or metachronous lesions are suspected, we have got these different types of tests. You can just remember the names. For example, the MIBG scintigraphy, 18F FDG PET scan. So they are definitely useful for metastatic PPGLs. So what we should remember ultimately here also is the best sensitivity test for the primary tumor localization is definitely the contrast CT, and it could be MRI also to the extent of 80 to 100%. Genetic testing has come into vogue mainly because the PPGLs have got the highest reported degree of heritability among all tumors. So we should consider them for genetic testing and counseling. It should be based upon clinical feature-driven diagnostic algorithms in patients who have got suspected germline mutations. There are different tests which are tried. For example, it's called a succinate dehydrogenase mutations in the patients, or metastatic disease for SDBH, HDHB mutations. So apart from this diagnostic tests and tests for localization, we can have other investigations. Definitely heart is one which is involved. ECG, the basic ECG, 12-lead ECG for LVH, SCT changes, and ischemia because of the alpha-adrenergic effects, QT prolongation, and others. Then it could be dysrhythmias due to electrolyte abnormalities also in these patients, or you can look for evidence of cardiomyopathy-induced changes. Echocardiography, you can look for left ventricular hypertrophy, ischemias, cardiomyopathy findings, or even primary cardiac pheochromocytoma. Sugar, I said, or the glucose metabolism, it is definitely affected in these patients. There could be elevated blood glucose secondary to the increased catecholamine secretion, resulting in increased glycogenolysis and inhibition of insulin release, and renal issues and fluid issues for the patient. We have to check for the creatinine, urea, hemoglobin, and also look for electrolytes, which also can precipitate dysrhythmias for the patient. So how do you medically prepare these patients? Basically, surgery is the only option for these patients, and we have to prepare the patient medically to see that we control the blood pressure, heart rate, and cardiovascular dysfunction, number one. Number two, as I told you already, it is the restriction of intravascular volume. Give high sodium diet and fluid restoration is tried due to catecholamine-induced blood volume contraction. And thirdly, blood glucose level and electrolyte level. So three main components have to be checked for in the preoperative preparation of the patient. And it could be an advanced endocrine disease or some syndromic associations. Normally, it takes about 7 to 14 days. We were talking about what is known as Roisen's criteria to check whether the adrenergic blockade has been effective, alpha-adrenergic blockade previously, which says that hospital blood pressure reading should be less than 160/90, 24 hours before surgery. There shall be no orthostatic hypotension with BP less than 80/45 millimeters of mercury. ECG should be free of STD changes for a week and no more than 5 PVCs every minute. So these criteria are still applicable, but slightly modified because the approach has to be customized to individual patient also. Broadly speaking, BP can be 130/80 in a seated patient, or it could be more than 90 millimeters systolic for a standing patient. So it is optimization. Heart rate could be 60 to 70 when the patient is sitting, or it should be 70 to 80 beats when the patient is standing. And hematocrit should be brought up to maintained at around 45 and not more concentrated. One thing we have to remember in terms of control of hypertension, that most of the pheochromocytomas are predominantly norepinephrine secreting. So the focus is on alpha blockade. In fact, we have got very good guidelines from the Endocrine Society, clinical practice related guidelines. And what are the advantages of using, for example, alpha antagonists, alpha-adrenergic antagonists? Of course, they are going to reduce the blood pressure for the patient. Plus, indirectly, they will be increasing the intravascular volume. It brings down the paroxysmal hypertensive episodes, allows resensitization of adrenergic receptors, reduces dysrhythmias, reduces blood loss, and others. And there will be always side effects for alpha blockers, including fatigue, reflex tachycardia, loose stools, somnolence, and nasal congestion. What you have to remember is in terms of alpha blockers, should I be using non-selective or selective alpha blockers? We should know that alpha-2 adrenergic agonism is it causes a reduction in the catecholamine secretions, which is a presynaptic effect. And alpha-1 adrenergic receptors are mainly postsynaptic in location, and they produce vasoconstriction when they are stimulated. Therefore, the non-selective drugs are classed separately. They mainly act upon the alpha-1 receptors, which is postsynaptic and have got some presynaptic effect. They cause permanent deactivation of alpha-adrenergic receptors. The selective one have got competitive alpha-1 effect. These receptors return quickly to normal function. Therefore, the non-selective ones, I told you, they are going to block the alpha-1 predominantly and some alpha-2 activity also. They have a strong block so that excess catecholamines cannot overcome the blockade easily, whereas selective alpha-1 blockers allow for normal regulatory activities of the presynaptic alpha-2 receptors. So they are not impaired. So what is the consequence? What do you understand out of this? Whenever there is a surge in catecholamines due to tumor handling intraoperatively, they are better withstood and countered by presence of non-selective alpha-1 or alpha-2 agonists in the antagonists in the circulation. And if it is we are using alpha-1 selective agents, which are generally short-acting, there is risk of severe hypertension overwhelming the competitive receptor antagonist. After tumor resection, there is a sudden fall of catecholamines. In such situation, if the patient is on non-selective drugs, hypotension refractory to alpha-adrenergic agonists can persist for days until new receptors are synthesized. Whereas if it is alpha-1 selective agents, that we can have early restoration of physiological regulation or vascular tone and blood pressure for the patient, and there is a less risk of post-op hypotension. So there is a huge list of the drugs, which includes the alpha-adrenergic blockers. For example, phenoxybenzaimine, which is non-selective. Then there is prazosin, terazosin, doxorubicin, which are selective. Virapidil, which is selective. So doses are recommended in terms of how they are initiated, how they are maintained, and what are the uses, whether it is for pre-op preparation or for intra-op control or for emergency use. Phentolamine is a non-selective drug. Then beta blockers have got a role. Magnesium sulfate has got a role as antidisturbic agents. Alpha-methyl paratyrosine. Then you have got a role for the calcium channel blockers, nicardipine and clevidipine, and usual vasodilators like nitroprusside and nitroglycerin for the patient, and phenoldepam. So this is a list of drugs. You can also go through it later just to understand the doses and their indications. Normally, the optimal duration of management or treatment would be about 3 days to 2 weeks or longer in majority of the patients. We normally talk about two drugs, phenoxybenzaimine, the non-selective drug, which has got longer duration of action, and doxorubicin, which is short-acting. The phenoxybenzaimine, if it is used, is advised to be stopped 24 to 48 hours before surgery, because it is possible that there is vascular unresponsiveness after removal of the tumor, which I told you already. So this is an advantage. And in fact, if it is not acting much, in some cases, we'll be able to localize areas of metastasis by hypertensive episodes. Of course, they are all dangerous. It is just a theoretical discussion. And some set of people also advise only 1/2 to 2/3 of the morning dose to be given preceding the day of surgery. Doxorubicin can be preferred, the short-acting one, the selective one, because there is lesser tachycardia, and we can titrate the dose to effect intraoperatively and postoperatively also. Which one will be preferred anyway? Ultimately, majority of the evidence says both phenoxybenzaimine and doxorubicin can effectively control the blood pressure and hemodynamic changes in this patient. In fact, it is said that even if the patient is normotensive and diagnosed PPGLs, they should be given preoperative alpha-adrenergic blockade to prevent potential risk of intra-op hypertension. So it is a comparison of basically phenoxybenzaimine and doxorubicin and picking up the best one for a patient. This was only randomized. This is the only randomized control trial involving 134 patients, a multicentric study which has been performed, where they compared phenoxybenzaimine with doxorubicin for about 2 to 3 weeks before surgery with targeted BP titration schedule. The primary endpoint was the cumulative intra-op times outside of the target range of blood pressure for the patient as percentage of total surgical procedure time. So basically, they found that there was no difference in the duration of blood pressure outside the target range during the cesarean, during the resection of the PPGL, whether you give phenoxybenzaimine or doxorubicin. Only thing they found was phenoxybenzaimine was more effective in preventing intraoperative hemodynamic instability. But whether the outcomes in terms of the patient recovery or the stability in the postoperative period, again, that was same in both the set of patients. We have got a practical ready-made protocol by the Endocrine Society practice guidelines. They advise the preparation one first to be started, phenoxybenzaimine and doxorubicin for about 10 to 14 days before surgery. The dose is also given. If there is no control, we can add nifedipine or amlodipine. Secondly, especially even higher doses are found to be necessary. And preparation 3 is adding beta blockers, so like propranolol and atenolol, which are added in these patients after we start alpha-adrenergic blockade. So why is it started? Whenever the alpha-adrenergic antagonists are started, we may have the patient developing reflex tachycardia, or patient per se could be having tachycardia, especially about more than 120 beats per minute. Then it is this is the reason that we start the patient on beta blockers. So it should be started only after initiation of alpha blockade, because if you initiate it first before alpha blocker, if you initiate beta blockade therapy for the patient, there could be dangerous elevation of blood pressure or even hypertensive crisis, because there will be unopposed alpha-adrenergic effects for the patient. So target heart rate is about 60 beats per minute. Which drug? We can use any of the drugs, especially propranolol, atenolol, lipitalol. epinephrine could, a small oil can be used if it is epinephrine secreting tumors. So normally in practice, we can have propranolol, atenolol being used for the patient. Calcium channel blockers are also added in some patients, mainly because calcium can also be a trigger for catecholamine release from the tumor. And this excess calcium can enter into myocardial cells and contribute to catecholamine-mediated cardiomyopathy. So they can reduce the blood pressure and they can reduce the risk of complications. This personalized management has also come into vogue recently. There are publications about this also. I told you there is a risk of genetic susceptibility in this set of patients of PPGL. There can be what are known as germline mutations, somatic driver mutations, or a combination of them. These could affect the phenotype, clinical behavior, long-term prognosis also in specific molecular clusters of patients. So next generation sequencing is advised as for every patient whenever it is possible in the current times. So this is the publication about the personalized management. So I will end with this here with respect to the part 1 of the anesthetic management of patients with pheochromocytoma and paraganglioma. We'll have the part 2 as the next presentation so that you understand first the part 1 better. In the part 2, I'll be covering the intermediate, the immediate perioperative considerations for the patient, certain surgical considerations, overall the anesthetic considerations for the patient. Thank you very much.